Good evening, Dr. Kshitij. Good evening, Tanushri.
Good evening, ma'am.
Good evening, everyone. Good evening, Dr.
Hello, good
Kshitij.
evening, Nitavin.
Hi, Nihal ma'am.
Oh, Sikha, it's Sikha. Hi, Sikha.
Good evening. Good evening, Neha.
Hi, hi.
Hmm. Take chorus.
Hi Nehal. Hi Tanushri. Good evening. How
Hi,
you?
Dolly.
Hi. How are you? Hi Dr. Kshitij.
Hello, ma'am. How are you, ma'am?
Hi Neeta. All good. So Tanushri all set to help us learn more. Hi Sika.
Hi, ma'am.
We'll wait another 5 minutes and we'll start, right? Dr. Kshitij, okay?
Sure, ma'am. It's okay.
Tanushri, I think we'll start. Tanushri, we can't hear you. Speak something.
You are
Can't hear
muted,
you.
Tanushri. You are muted.
No, she did unmute, but I don't know. I can't hear.
Is the
Can you
cord
connect it
connected
to
to
the
your
audio?
laptop?
Shut it and start again, I think. Leave and rejoin.
No, you're still not audible.
You want to try logging from some other device, Tanushri? Can't hear you at all. Sika, can you call her up and talk to her?
Yes, sure.
Yeah, call her up. No, tell her it's, probably she can try joining from the phone or something. So, Sika Aditi Singh, tell her try without the earphones maybe.
She's trying to log in from a different device, ma'am.
Can you hear me now, ma'am?
Yes, yes, we can hear
Yeah,
you
now you're
now.
audible.
Done. Thank you. Sorry for that glitch. Sorry.
Now, ma'am, you are muted, huh? Nehal, ma'am.
Yeah, ma'am, I think we
Sorry.
should start. Yeah.
Okay, yes. So, good evening, everybody. Sorry for that little glitch. And I welcome you all for this Webflix season 2 and the 4th episode of this year, 2024. And today we are going to have our special topic of interest as pediatric cardiology. And we have with us Dr. Kshitij Sheth. So I was just going through this very small, concise CV, which speaks volumes about what he's specialized in. And of course, he's a consulting pediatric cardiologist. He's attached to the SRCC group of hospitals and a director of the Sheth's Healing Hearts Cardiac Clinic at Vile-Parle and Borivali. He has lots of degrees of different kinds attached and affiliated to his name. And of course, his special interest is neonate and complex cardiac interventions. He's an interventional cardiologist. But today, Dr. Kshitij, you have to make it very simple for us. Most of the crowd is a general practicing pediatricians. So although your interest and your expertise is in complex, try and make it very simple for us. And to moderate the session with us today, we have a very young and very enthusiastic EB member of IIP Mumbai, Dr. Tanushri Mukherjee. She's a consultant pediatrician and neonatologist attached to the Cloud9 group of hospitals. And of course, her special interest is also in high-risk newborns and preterms and nutrition of preterm babies. So with both of us, we know that we are going to sail through today in the basics of pediatric cardiology as far as a general pediatrician needs to know. Thank you so much, and over to you. So, as always, we will request questions put in the chat box. As and when that topic is being taken up and discussed, they will address the same. So, over to you, Tanushri. You can start.
Thank you. Thank you so much, ma'am. Sorry for the initial 1 minute glitch. As Nehal ma'am has said, I'm really, very happy and in fact honored to be part of this Webflix series that has been, started with IFP. Uh, though it's very difficult to cover all the pediatric cardiac topics, as Nehal ma'am has just said. So we will start with the office practice pediatric cardiology, what we see in the office practice day-to-day life. So, Kshitij, to start with, suppose, as a pediatrician, we do see a lot of patient coming with cough, cold every day. So, out of that, which are the patients we should suspect a congenital heart disease? And is there any routine screening we can do for this, in early life to screen the congenital heart disease?
So see, most of the times what patients we see in the OPD with cough, cold, by and large, they have respiratory infection. But a small subset of them will be having underlying cardiac problem, which might be giving rise to the respiratory infections. So if mainly you look at the history, whether there's a history of failure to thrive, suppressed cycle, signs of cardiac failure, and along with that, any physical findings of tachycardia out of proportion, respiratory distress out of proportion to the infection that you're suspecting, or you have a murmur, loud second heart sound. So if you have any of these on X-ray, if you have a cardiomegaly, an unusual patch which you would not expect, in those cases, I think you should think in terms of cardiac problems. But in early life, I would say in newborn period, it's very important to screen for complex cyanotic heart disease. So pulse oximetry is very important in newborn period. There is a screening test which has been developed by the American Association where you check the saturation of the baby at time of discharge or at least 24 hours after birth. So in that case, if the saturations are more than 95%, then you don't suspect critical cyanotic heart disease. And in this case, you check both for the upper and the lower limb pulse, upper limb, right hand preferably, and either of the lower limbs. So if the saturation is more than 95, you usually rule out critical congenital heart diseases. But if the saturation remains somewhere between 90 to 94, or there's a upper limb, lower limb difference of more than 4, then you repeat the test after 1 hour. Again, if the difference is still more than 4 or saturation between 90 to 94, then what we call as a failed screening test. In that case, you need to refer to a pediatric cardiologist. And if the saturation less than 90, just straight away refer to a pediatric cardiologist. So this is screening in newborn period, but those who present later on in life, they would not be having these critical heart diseases. They would be having more likely to have shunt lesions like a VSD, a PDA, which will be missed by the screening test.
Thank you. So it will detect only your congenital critical cyanotic heart disease mostly. Rest of the things, so that will be missed. So you talked about murmur, in the OPD, sometimes we see the well babies who are coming just for a routine vaccination. So I have a 9-month-old or 1-year-old coming for a vaccination, developmentally all good, general health is all good. Now on examination, I found a 2/3 or 2/6 or 3/6 of systolic murmur. So can I just take it as a innocent benign murmur, or should I send it for an echo? Or what are the pathognomic thing that we shouldn't miss out to have a pathological murmur?
So see, by and large, in our practice, if we see around 70% of babies will have murmur at some point in time. Now, whether it is pathological or innocent benign murmur, you have given the answer in your question itself. So if the child is well grown, thriving well, no symptoms, parents have no concerns, and you hear a murmur for the first time, I would just suggest you to mention it to the family that there's a murmur, but not to get panicked about it. But if you hear a murmur more than on one occasion, then I think it definitely warrants some sort of further investigation. So benign murmur, typically the history will be that a child is a well-grown normal child. It will be a soft systolic murmur most of the times, low-pitched murmur with sometimes a musical tonality to it. You could have a continuous murmur in form of venous hums as well. And very commonly, what you could do in the OPD is just change the position of the baby and auscultate carefully. Those murmurs which are benign will usually become softer or disappear when the child is in lying position and be more prominent in a sitting position. And if with that, if the second heart sound is normal, there is no diastolic murmur, there are no physical signs of cardiac failure, no cyanosis, then you are most of the time sure that it's a innocent murmur. If there's presence of pallor, yeah, it could be a hemic murmur as well, which is similar, which is a type of innocent murmur with anemia. So, if the child is thriving well, no other symptoms, then most of the time it's a benign, uh, innocent murmur. But I would like to put in a caveat that there are some cardiac conditions which could be missed, which could be like a atrial septal defect or a partial anomalous pulmonary venous connection, where the child is asymptomatic in pediatric age group, and these kids they become symptomatic later on in life. So if you hear a murmur for the first time, call the child back. Most of the time, these murmurs are heard during episodes of cough, cold, fever, where it's a high output cardiac state. So call them back when the child is well. And again, if you hear a murmur, better get it evaluated.
Thank you so much. I think this change of position, it's such an important clue that sometimes we don't do. I think now on, we will also follow that supine and sitting position, auscultating the baby. Now, moving on to our next topic, so suppose I have a patient who is a 2-year-old with a moderate VSD. So does this baby need intervention, or which are the baby, who need immediate intervention, and which are the babies where we can wait for the intervention for a
So you
congenital heart
want
disease?
to include neonates as well?
Mainly pediatric, yeah, but you can touch upon on the neonates as well.
So starting from neonatal period, those babies which require early intervention, immediate intervention, I would say one first of all, a newborn period would be an obstructed total anomalous pulmonary venous connection, obstructed TAPVC, and then duct-dependent lesion like a ventricular septal defect with pulmonary atresia with intact septum. So wherever there's a PDA which is supplying the pulmonary blood flow, in those cases they require intervention at birth. Also, critical valvular lesions like critical aortic stenosis, critical pulmonary stenosis, they are the ones who require immediate intervention at birth or a significant coarctation with ventricular dysfunction. If you ask me in a older child or an infant, so those means it would not be, I would say, urgent attention, but early intervention I would suggest in cases of what we call as post-tricuspidation, that is a ventricular septal defect or patent ductal arteriosus, where there are large shunts which could lead to increase in vascular disease over a period of time and isomengerization. Those babies usually require early intervention in the first few months of life. In these cases, if we wait for long, beyond 2 to 3 years, they might become inoperable. So it is important to operate them in that time. The commonest cyanotic heart disease is the tetralogy of Fallot. So in those cases, we usually operate them electively by 6 to 9 months of age. They might require early intervention if the child is really blue, saturations are less than 75, getting repeated episodes of cyanotic spells. In those cases, we might need to intervene early. And as the question that you asked was a moderate ventricular septal defect, moderate VSD. So basically, VSDs, if it's a small VSD, they don't require intervention. Only if it is the VSD is causing some harm to the surrounding structures like aortic valve prolapse, giving rise to aortic regurgitation, or the child is developing some RVOT obstruction. Those are the small VSDs where they require surgery. Moderate VSDs, they have a component of ventricular overload. That is, the left heart is dilated. So these lesions, we usually try to tackle them by 2.5 to 3 years of age. So if the going by the natural history, if you see, the rate of closure of VSDs after 3 years is very less. So if by 3 years the child has a moderate VSD, it is by and large unlikely to close down. And in the long run, if we leave that VSD with a dilated left heart, that left heart failed in the long run by 30, 35 years. So it is better to close them by preschool age, around 3.5 years. If the moderate VSD is still open, better to get them closed.
So that will depend for a VSD, that will depend on the type of VSDs and the diameter of the VSDs and all those things, position of the VSDs as well.
Correct. So moderate VSD at 3 years would require closure. The type and the location would determine the mode of closure. Like if it is a perimembranous VSD or a muscular VSD, it is feasible to close these defects by intervention doing a device closure. But it is say an inlet VSD or an outlet VSD or the subaortic VSD close to the aortic valve. These are VSDs which will require closure, but it would be a surgical closure. So the indication for closure will not change, but the modality might change depending on the type of VSD you have.
Okay. Okay.
But similar in terms of PDA, it's a little different. PDA is the direct connection between the aorta and the pulmonary artery. So in those cases, we don't wait beyond 6 to 9 months for closure of a PDA. Because if the PDA doesn't close by 9 months in a preterm baby or by 6 months in a term baby, it is unlikely to close. So in those cases, our threshold to intervene is less. So we close them within the first year of life.
Yeah. So it's almost, with that, my next question, that age criteria you told, but is there any weight criteria as well before we take them for the surgery or intervention?
No, there's no weight criteria for any of the surgeries. So most of the surgery in current era, even the smallest babies can undergo surgical correction. Yeah, definitely the outcomes might vary depending upon the complexity of the surgery and the weight, but there's no weight criteria. So initially, it was said that weight for 10 kgs for a VSD surgery. By the time that because of the large VSD, the child will never gain weight, and by the time you wait for 10 kgs, he might just go into Eisenmenger phase. So there's no weight criteria. Yeah, but mostly it depends on the timing of the surgery, depends on the clinical condition and the age of the child. So if the child is symptomatic, not controlled with medication, then there's no point waiting. We only wait in cases where there's chances of spontaneous improvement or the child is fine and we can just wait. Like you say an ASD, atrial septal defect.
Yeah.
So ASDs are by and large asymptomatic in pediatric age group. They don't have symptoms. Less than 5% of ASDs become symptomatic. So ASDs, we wait till 2.5, 3 years and close them electively at that stage. Because as I said, if it is left open over a period of time, ASD will develop right heart failure when they grow up. So it is better to close them by preschool age.
Yeah. And any pre-op medications that you give, or medication that you
So
prefer?
medication by and large are just temporizing measures. There's other than paracetamol or ibuprofen in the newborn PDA, there's no other medication which is going to treat the condition. These
Okay.
medications are basically temporizing measure to stabilize the child. So as I said, if it is a large VSD and the child comes to you by 3, 4 months of age, we do start them on diuretic, ACE inhibitors, but they will ultimately require surgical correction. Medications are helpful in cases of moderate lesions, like a moderate VSD, who comes to you by 6 months or a year of age. And you start him on medication, hoping to improve the symptoms. This helps you to buy time for the natural history, where if at all the hole is going to close, that will be helpful. But if not, if the child is still symptomatic with medication, you will have to intervene early.
And
And also, these are, as I said about shunt lesions. ASDs by and large don't require medication. Yeah, in those cases, if the ASD child has got some sort of respiratory infection which is not improving quickly enough, in those cases, you can give a short course of diuretic, which might be helpful. But there are other conditions like valvular lesion, like a mitral regurgitation or aortic regurgitation. In those cases, medications are very helpful. These we use ACE inhibitor, that is the afterload reducing agent, which will help in improving the symptoms. Also, it will delay the dilatation of the left heart, which might in turn help in delaying the surgical intervention for these patients. So mainly for valvular lesion, is the medications are very helpful. Otherwise, it's just a temporizing measure, and they will most of them will end up requiring surgery.
Okay.
And also, if they'll put in a word regarding tetralogy of Fallot or a cyanotic heart disease with of physiology. In those cases, beta blockers are very helpful. So if the child is really blue, you can start them on beta blockers till they are ready for surgery. And also they require iron supplements because they have a lot of ineffective erythropoiesis. So in those cases, beta blockers are really helpful.
Okay, okay. Now, the post-intervention, sometimes, these are the patients, they normally follow up with a regular pediatrician. So how we should follow them up? Suppose I have, one post-op top patient who has been operated. I have a co-op patient who is operated, and I have a very complex cardiac disease operated, just as a physiology. So in OPD, what are the things we should
Yeah.
check for?
So I'll go by the commonality. So as VSD is the commonest heart disease, the most common patient that we come to you for follow-up would be a VSD closure. So VSD closure is usually most of them, it's a curative procedure for them. Most of them, they will, after the procedure, they might not require anything else in future again. So these patients, we follow them up after surgery with a day follow-up of 1 month, 3 months, 6 months, and then yearly for at least 5 years. So if at the end of 5 years we feel that the child is doing fine, there's nothing going wrong, I usually discharge them by 5 years of age. In case of a ASD, VSD, or a PDA, they will be coming to you for follow-up routinely. So for what you can look at is after the procedure, you anticipate growth in the child, weight gain in the child. So is the child gaining weight normally after the procedure? There will be some amount of catch-up weight gain. Also, you will have to examine the child for any signs of cardiac failure. Sometimes, rarely, you might have maybe a patch dehiscence or a valve lesion which is present. And those cases, you might have red flags of cardiac failure. That is what you'll have to monitor. Basically, you'll have to monitor symptoms and weight gain. Coming to cyanotic tetralogy of Fallot, by and large, tetralogy of Fallot, around 20 to 25% of those patients will have a lesion and they might require intervention in future. Residual lesion, as in, because in tetralogy of Fallot, as you know, there is a right ventricular outflow tract obstruction. So if it is very severe, we might have some, many times what we do is put in a transannular patch, that is, we remove the pulmonary valve completely. So these patients will have a free pulmonary regurgitation. And when they grow up by adolescence, they will require a competent valve in that position. So these patients, when they come to you for follow-up, again, you'll have to monitor for signs of right heart failure, whether they have enlargement of the liver, whether they are developing puffiness of face or edema of the feet. Those are things that you need to look at. Coming to intervention, like coarctation. In coarctation patient, it be it surgical or interventional by ballooning or stenting, these patients have a tendency to develop hypertension. So it is very important to measure blood pressure at each follow-up. And blood pressure beyond 3 years of age is mandatory. Before that, if some condition like coarctation, you need to measure the blood pressure. And post device closure, most of the patients who have undergone an ASD and VSD device closure, they will be on aspirin. So when you have to make sure that when the child has some respiratory infection or something, you try to withhold the aspirin for a couple of days. There's a risk of Ray's syndrome developing. So for a couple of days, you might have to withhold aspirin. That's what you have to advise to the family.
Okay. So I think that main thing is just watch out for the heart congestive cardiac failure. That is the main thing that we have to look in these babies. So you
Put it
already
short that any pre-operative symptoms coming back.
coming back. Yeah, yeah. So you already mentioned about the medication, ACE inhibitor, diuretic, aspirin, and everything. So when we see the monitor the side effect of these things, so whether the clinical, that checkup is enough, or should we go for any blood test as well when we are monitoring the side effect of the drugs, or anything we should look for?
So basically, when we give the medication for long term, we usually ask for monitoring of like if we use a ACE inhibitor or digoxin or for that matter diuretics, we ask for renal parameter, that is creatinine and electrolytes every 3 to 4 months, just to keep a watch on toxicity. When we start ACE inhibitors in the first year of life, we have to be more careful. I have seen in my life, I would say at least 3 patients who ended up with acute renal failures after giving ACE inhibitors. So in pre-operative patients, I usually prefer diuretics and try to increase the diuretics. Less than 6 months, even though the books mention giving ACE inhibitors, I personally try to avoid it. If the child is not improving or not stabilizing diuretics, better to undergo surgery rather than take a risk of giving ACE inhibitor and ending up with renal failure.
Okay. Dr. Nehal ma'am is asking, what clinical signs help us to monitor improvement versus worsening in patient with shunt, with a conservative management patient?
So, in shunt lesion, as I said, symptoms would be not gaining weight, having fast breathing, suck rest suck cycle, and repeated respiratory infections. So, if on medication, if the child is improving, you will the one parameter that I usually look at is the weight gain. If the child is failing to thrive and then again starts gaining weight, that would mean that the child is improving. There is a caveat that it could be worsening of pulmonary hypertension, but then auscultatory findings do help you. If the child is improving and the second heart sound is soft and not having other signs of cardiac failure, it is more likely to be improvement rather than deterioration. But one parameter that I usually look at is the weight gain, because if the child is starting to thrive well, definitely there is signs of
Doing good.
improvement.
Yeah. Sometimes, we see that residual murmurs, it's still there in the patient, even after post-intervention, post-surgery. So as a pediatrician, when we should be alarmed that, this is just a residual murmur and it's not the old thing coming back, and refer
So
back to.
for this, what I usually suggest is once the first time the child comes back to you after surgery, go through the echo report, look at what residual lesion the child has. And if say if a large VSD, the child has undergone a closure for large VSD, sometimes there's a small residual VSD remaining. But you see that on the report, on the pre-discharge report, and then you auscultate, you find a harsh 3/6 murmur. On follow-up, if there is change in the murmur quality, child remains symptomatic, not gaining weight, or a new murmur has come up, then it has to raise a red flag. But if the child is otherwise doing well, gaining weight, feeding normally, off medications, and you still hear a murmur, by and large, it is a residual lesion which might not be very important or significant. Like you get residual lesion murmur in case of VSDs, you will get it in case of ballooning of pulmonary or aortic valve, they will have residual murmurs. But it should be the child should be improving after the procedure. In that case, the murmur might not be that significant. And also, when the patients come to me, I on my paper mention it specifically whether the murmur is, because the best tool to evaluate would be a 2D echo. I put it on paper whether the residual murmur is hemodynamic significant or not. That is the easiest way from our end to guide the pediatrician, because echo would be more definitive and confirmatory. So it is better to put it on a paper on our end whether the murmur is hemodynamic significant or not.
Yeah, I think for us also, just to see the first echo post intervention, document it, write it somewhere where we can see it every time, and that will help
You
us to
just make a
identify.
note on the side that
Make a
he
note
has a
of note.
residual
Yeah, yeah.
small
This is the
VSD or mild pulmonary
yeah.
stenosis. Just make a note somewhere so you know that every time you hear a murmur, you don't get tensed about
Yeah.
it.
Sometimes, the parents, they ask us about the physical activity, the sports, what are the things that the parents, the patient can participate, like swimming or football or something. So how we should counsel them?
So most of the patients who undergo corrective surgery, they can lead a normal life. So beyond 1.5 month of rest, they don't require any sort of restrictions. Most of them would be able to do everything, including competitive sports as well, be it a VSD, PDA, ASD. But sometimes you need to be wary of what kind of medication. Like if a child has got a stent, he might be on aspirin, or if has got a prosthetic valve or a conduit, he might be on blood thinners. So in that case, you need to make sure the child is off any competitive sports or contact sports, because many times these kids might get into karate or judo, and contact sports could be dangerous to patients who are on aspirin or warfarin. That you need to make sure. Also, if the child has got some residual lesion which is significant, like say tetralogy of Fallot having a significant residual pulmonary stenosis, or severe PR where we have put in a transannular patch. Those patients can have a normal quality and life. They can go to school, but they should avoid from getting into competitive sports. Also, sometimes these patients with Kawasaki disease who has had a coronary dilatation, they will be on aspirin. They need to avoid contact sports. I tell them self-limited activities. As much as the child can do, he should be allowed to do, but you should not push him further beyond his capacity.
Okay, okay. And you just mentioned about the transannular patch in top or the coarctation. So which are the patient that you will think of needing a re-intervention? We can counsel them.
So, usually ASD, VSD, PDA, they are one time they are done, they don't require anything. Tetralogy of Fallot is one subset where around 20-25% would end up with requiring another intervention where we have put in a transannular patch and they require further surgery or a valve implantation. Also, aortic valve, when we do a ballooning of the aortic valve, it's a bicuspid valve most of the time. So per se the valve is made abnormal. So we are just temporarily improving the valve function, but in the long run, those patients will require valve replacement. So they require lifelong follow-up. Coarctation aorta, they are known to have restenosis, so they require lifelong follow-up. Then a complex heart disease like transposition of great arteries. There, what we do is we change the aortic and the pulmonary valve position. So in those cases, the pulmonary valve which is there at birth is going to be the future aortic valve. So those tend to damage over a period of time. So these are conditions where they require lifelong follow-up, or a univentricular heart where they have undergone a Glenn shunt or a Fontan completion. These are patients who require lifelong follow-up.
And may need some amount of re-intervention in some form as
Yes,
well.
yes,
Okay.
at some point in time.
Some point in time. Dr. Kshitij, Dr. Deepa has just asked, like, do you use digoxin in the management of moderate and severe VSD apart from the diuretics?
I tend to use it. If you go by the literature, the if you see the literature, it just shows that because VSD and PDA are high output cardiac state, in those cases the function is normal, but giving digoxin has shown to have symptomatic benefit. And also, as I said, I don't use much of ACE inhibitors in younger kids. So if I'm struggling with diuretics, I do add them for management of shunt lesion preoperatively. But many of the people might disagree considering the toxicity, but I just use oral medication. I don't load digoxin, just start off with maintenance of 10 microgram per kg per day. And also I give drug holiday, that is twice a week. We withhold the medication so as to avoid toxicity.
Okay. And just as a pediatrician, vaccination is one of the things that's why the patients are coming. So any vaccination that you will, emphasize on, you just mentioned about the aspirin and Ray's syndrome for pre-op or post-op patients.
So pre-operatively, all kids should receive normal vaccination. No vaccine should be withheld. In shunt lesions, it's better to give them the pneumococcal and the seasonal flu vaccines so as to prevent respiratory infection. And post-operatively, because the child has undergone, say, a surgical closure, in that case, the child has gone on bypass, so where we give blood, lot of blood products. In those cases, we avoid the vaccination for first 6 to 8 weeks post procedure. So we advise patients to start vaccination only after they have come to our first month follow up and then restart the vaccine. There is a controversy regarding giving live vaccines because of so much of massive transfusion. So if you go by the vaccination books, they say after transfusion or after IVIG, they need to wait for 11 months. But we usually tend to give live vaccines after 3 to 4 months
Okay.
post
Okay.
transfusion. Yeah.
So at whatever age the operation happens, after that, whatever the patient got, it's there. After that, you don't restart the vaccination schedule.
You never
Whatever,
restart vaccines.
never,
In any
right?
case,
You
you
just
never restart
whatever,
vaccine. You
yeah,
just
whatever is
continue
left
it.
over, you just continue with the
Yes.
vaccination.
Yes.
And as we know that, the infective endocarditis prophylaxis initially used to read a lot of indication. Now it has come down a lot. So what are the patients exactly where you give infective endocarditis prophylaxis and what are the procedure? You know, and same.
So basically, infective endocarditis prophylaxis, if you go by the guidelines, now there are very few indications remaining. One is if the patient has received a prosthetic valve, or there is a history of proven infective endocarditis, or post procedure where there is in cyanotic patient with a residual lesion like post BT shunt or a Glenn shunt. And fourth is post procedure for 6 months in case of device closure. So these are the only indications now mentioned by the guidelines which have been published in the West. But if you go by our kids and the kind of dental hygiene that our patients have and kind of infections we have, I usually prescribe prophylaxis for all my patients. It is just giving one dose of amoxicillin prior to a procedure like a dental extraction or a urinary tract surgery or a GI surgery. Single dose of antibiotic, I don't think will cause much of a resistance. But if the child develops some kind of infection or develops infected enteritis, it would land up in major trouble. So I still recommend giving prophylaxis in all my patients with congenital heart disease.
Okay.
Only bearing a few like ASD or a PAPVC where the risk is very, very minimal. But whenever there is a high pressure gradient like VSD, PDA, aortic stenosis, in those patients, I definitely still recommend giving
Yeah.
infective endocarditis prophylaxis.
I think Nehal ma'am, I think you also asked almost the same question. So now coming to our another very important topic that very commonly we see that the a adolescent girl mostly who are coming with an transient loss of consciousness, giddiness, so that we see as syncope or vasovagal attack. So how we should investigate whether on the first time we know it's a vasovagal attack, we should counsel them, give them the measures, go back, and or whether we should wait for the multiple episodes and then we should start investigating these kids.
So syncope, by and large, if you ask me, it is mainly a clinical diagnosis. History is the giveaway to a diagnosis. Most of the syncopal events are vasovagal in nature. So basically, if what I look at is whether there is a prodrome present, whether what is the situation, and what kind of activity the child has been doing at that time. So if you have a typical history of vasovagal where the child has been standing for long, or the change in position of the child is having episodes, or if the There is some child is standing in the assembly, which is the commonest what you get in school kids, or with sudden pain, sudden trauma, they get these episodes. Then I would just think in terms of vasovagal and not investigate at the first instance itself. But if there are more than two or more episodes, I would definitely document some sort of investigation to see that it's not something life-threatening that we are missing. Given that, it is very important, first of all, to differentiate whether it is syncope or a seizure or it is psychological. So many times we have these kids who have some sort of mental fatigue or distress, and they many times come with psychogenic problems. So it is history is the main important thing, that you dig into the history to find out whether it is really vasovagal or something else.
So suppose, like you just talk about investigation, so you do that head up tilt test, or you do some other investigation when you are investigation these kids?
See, investigation wise, one investigation, if you ask me what we need to do in a case of syncope, I would say it is ECG monitoring. So syncope, as I said, most commonly is vasovagal, and the most life-threatening are cardiac. So if you see a child and the child examines well, there is second heart sound is normal, there is no murmur, there are no signs of cardiac failure, then by and large you have ruled out most of the cardiac causes, because the cardiac causes would be either a structural abnormality or maybe a cardiac dysfunction causing cardiac failure, and structural abnormality give you a murmur, or there's pulmonary hypertension where you have a second heart sound which is loud. So if you rule out structural and functional causes, what remains is arrhythmia. So if there is a baseline abnormality in the ECG, like a pre-excitation, or there are multiple VPCs coming on, or there's a Brugada pattern, or a long QTC, then those things can be easily picked up on ECG. So if a child is examining well and there's nothing else, then I would just first investigation I will do is a ECG.
Yeah, Dr. Jagruti has just asked any role of 24 hours Holter monitoring in these patients.
So we do recommend 24-hour Holter monitoring in few patients. So basically, as I said, history and the background will determine this. If there is if the child complains of say palpitation prior to the episode, and every episode is during having palpitation prior to it, it would suggest some sort of arrhythmia which is there underlying. So in that case, if the ECG is normal at baseline, I would go, and otherwise everything else is fine and the history doesn't fit into a vasovagal syncope, then I would definitely go in for Holter monitor. But saying that, the pickup rate for abnormality in a Holter for any sort of arrhythmia, leave aside with syncope, without syncope also just picking up arrhythmia on Holter, the positivity rate is around 6 to 8%. Because when you put up a Holter, the child should have an arrhythmia at that point in time, only then you will get a positive Holter. So to increase the yield, I recommend usually 3 to 7 days of Holter, depending on the symptoms. If I feel that there's a high chance of getting if the episodes are very frequent, in those cases, Holter definitely helps to make a diagnosis. You might be lucky enough to pick up a arrhythmia on the Holter, but most of the time we end up having a normal Holter.
Okay. So just, that, so what are the red flag signs that, we should see, like in these patients when we are.
So, as I said, the situation or the history, whatever you get, it
That's
will
very
make you give you a diagnosis of vasovagal. So, red flags would be first and foremost having an episode during activity, or when the child is running and he collapsed. It is much different than a child ran, he stopped, and after that he collapsed. These are two different things. So, if the child while activity had an episode of syncope, it is usually a cardiac syncope, and we try to investigate further. Secondly, if there's a history of palpitation preceding the episode, or if there are cardiac findings of, say, a murmur or a loud second heart sound, or if there's a syncope in lying down or sleeping position. So, if that happens, then you have to think in terms of cardiac lesion first. and these all could be life-threatening. Also, if there is a history of, say, familial cardiomyopathy or long QT syndrome, or history of a pacemaker in some of the relative at an early age, or a
Sudden
sudden
cardiac
death
arrest in the
where there is
family.
no cause known. All these cases, you need to be very sure that you're not dealing with cardiac syncope.
So I think just to exclude arrhythmia and part of the arrhythmia, just and pointed history towards that.
Yeah.
Dr. Rajesh Kasla has just asked, please suggest a good, user-friendly ECG machine and NIBP machine for the OPD practice.
So ECG machine, I think BP, there are a lot of companies available, BPL, GE, Philips. Uh, for a pediatrician OPD, I think it is more important to have a NIBP and a pulse oximeter rather than ECG. ECG will not be required as frequently in a pediatric OPD practice, but I think BPL is a good cost-effective company to have an ECG machine. And NIBP also, there are a lot of companies like Mindray, GE, Philips, which make these NIBP machines. So you could use either of those.
Okay. Shruti, just going on to our next topic that, Kawasaki. I know Kawasaki disease itself is an 1 hour talk for you. So I'm not, uh, I'm not asking about actually the treatment and the diagnosis. Sometimes, once the baby is diagnosed, we give an IVIG and aspirin. Sometimes it's very important that the follow-up of the patient. So we treat the initial time, but then after this initial treatment, how to follow up that? Like, when we should ask them for a repeat echo, like what are the blood tests? Suppose CRP, yes, sir. What are the intervals we should do it?
First of all, it depends on each dog. As you know, Kawasaki follows we know to protect it. The first echo is the first week of the illness, phase of illness.
Your voice is very cracked.
Your voice is cracking a lot, Dr. Kshitij.
Audible now.
Yeah, little better. Yeah. Talk now.
We uh, go within the first audible.
No,
No, no, no.
It's still cracking.
Yeah, better. Just say something. No.
Oh.
Yes, better. Yeah.
So when first echo is the 2 days of fever, within the first fever, I would ask them echo to 10.
Not heard again.
cracking.
You can switch off your video and just see if it is a connectivity issue.
There could also be an issue related to the earpods that he is wearing.
Yeah,
Got logged off.
Yeah, is this fine?
Yeah, this is better.
better. Hmm.
Yeah. So when it is in when the first echo is done within the first week of illness, I would again ask for an echo by 7 to 10 days, just to make sure to look at the progress in the coronary dilatation. And also, and after that, a follow-up echo at 1.5 to 2 months after the illness. Blood wise, I would recommend to get a CBC and a CRP. ESR is not very helpful because it comes down very something that I would monitor to look at the disease activity. And if there is no coronary abnormality in the to begin with, and at 1 month or nothing, I would just discharge the patient and just one follow-up echo after a year to document everything is normal. But if there is coronary dilatation, then I would ask for lipid profile on follow-up.
And if the patient is having some coronary abnormality, so till what time, from cardiologist point of view, you follow up this patient, like every yearly, or then every 2 hourly, 5 yearly, something like that?
So as I said, if the coronary abnormality is resolved by the first follow, the second follow, that is at 2 months of age, then one more follow-up at 6 months a year to see that everything's fine, and we would discharge the patient. If there's any residual lesion, then I would for long till such time resolved or might require some long follow-up.
And the same for the medication as well. We start with aspirin, and that is the 6 to 8 weeks of aspirin. But suppose this baby is having some coronary abnormality. So for how many days this antiplatelet agent to be give we should continue?
So if the patient has got a giant aneurysm, he will also require anticoagulation with warfarin. If there is just plain aneurysm, normal, there's a vessel with aneurysm, require dual antiplatelets. It may be lifelong, and you need to treat
Lifelong.
them like an adult. Pediatric. So they'll require tight lipid management and as well platelet for lifelong.
Okay, okay. And Kshitish, in between, we were seeing a lot of patient like simple adenovirus infection as well with a very high CRP, and it was almost looking like an, atypical Kawasaki kind of disease. So, is there any role of IVIG on those atypical patients?
See, if you don't have cause and a fever going for long inflammation, I would err on the side of giving IVIG. If you have cause now, I would probably treat that underlying like Kawasaki.
Okay. Dr. Ripa is asking about post-COVID. We are seeing POTS, POTS.
Yeah.
How to manage this condition and when to consider any medication?
So POTS basically it's there even without a lot of adolescents, mostly females had it. It's mostly postural orthostatic tachycardia
Dr.
symptom.
Kshitij,
Yeah.
sorry to interrupt
Mhm.
you. Can you try talking without your earpods, your earphones?
I'll do that. Yeah, am I audible?
No, the volume is very less.
Okay, is it fine?
Yeah, this is good. This is
I'll
good.
speak louder. Yeah.
Yeah, I think now you can
Yes.
switch on your video also. Switch on your video, Kshitish, then.
Okay.
Yeah,
Yeah.
much better. Yeah.
This is good.
So POTS basically, there's you have orthostatic hypotension and tachycardia, which change in position, the heart rate increases, the blood pressure drops. So the best thing that they need to do, most important thing that they need to do is have proper hydration. At least I would advise at least 2 liters of water per day. And with that, if the symptoms are not improving, then they might sometimes require drugs like fludrocortisone or midodrine. These are two drugs that I usually use. But less than, I would say, if they are well hydrated, they wear pressure stockings, they take measures to uh, strengthen the leg muscles, then very less than 5% of them require medication. Most of them do well with hydration and pressure stockings.
Okay. Just a small thing about this, resistant Kawasaki we have given 2 doses of IVIG, and even after, so there are around 10-15% of the Kawasaki disease who really doesn't, respond so well. So is there any role of corticosteroid or your infliximab or etanercept in all those patients?
I would leave that question to Shikha, but if
Yeah,
given
it
the
is
choice,
Shika's question.
I means if after the first dose of IVIG, if the child has not responded, I usually advise for second dose of IVIG along with corticosteroid. And if that doesn't work, then probably antibody, infliximab or something of that
We'll
sort.
refer to Shika then.
I think referring to Shika is more important.
Yeah, thank you. So, I think with this, we will move on to our next topic, that is hypertension. That as we know that, hypertension is mainly an asymptomatic disease, and by the time the patient is having symptom, either it's an target organ damage or it's very sustained. So suppose I have a 13-year-old who came with around 118 by 82 BP, where the father or the grandfather is all hypertensive. and the baby is around 50th percentile on the height and the weight category. So how I should, see this patient, like how to investigate and uh, his, how
No,
you
so
should evaluate this one.
118 or 180? I didn't get you.
So the adolescent boy came with an high blood pressure. That is, so then how we should evaluate the patient?
So basically, one reading of high blood pressure, I would not label it as hypertension.
No.
It could probably be white coat hypertension. So I would recommend at least 3 readings on separate occasions. And every time if you have a high blood pressure reading, then I would label it as hypertension. And for hypertension, so there's this new guideline which came out in 2022 where it defined hypertension. So in kids who are less than 13 years of age, in those patients, blood pressure. Hello,
Yes, yes, we can hear you.
am I audible?
Yeah, we can hear you. We can hear you.
Yeah. So if it is the blood pressure range is less than 90th centile, it is normal. Elevated blood pressure is 90 to 95th. Stage 1 is 95th centile plus 12, up to 90th, 95 to 95 plus 12, and then beyond that is hypertension, stage 2. So rather than classifying the stages, it is more important to know when to intervene. So if you have 3 readings which are really high, then I would ask for an ambulatory blood pressure monitoring. And if that too shows high reading, then I would start the child on intervention, not medication straight away. Intervention means, first of all, diet, regular exercise, salt restricted diet, regular exercise, healthy food, and again recheck after 3 months. If the blood pressure doesn't show any change, then I would consider pharmacotherapy.
Okay. And which blood pressure this chart we should refer to?
So, see, if it's very difficult to carry charts with you. So, what I usually, if you see the chart by Myung Park, what he had published maybe in 2002 or something, if by 5 years, blood pressure 90th centile is 103 by 65, and you just keep on adding one per year following subsequently, so it comes to around 120 by 78 or so. So, but any reading more than 120 by 80, it should raise a red flag, and then you should monitor it closely.
Okay. I think in your previous talk, you mentioned that after 3 years, we should see blood pressure in all our patients. Like that should be as a regular checkup, we
Yes,
should
yes,
check.
this I would
Like,
recommend
is there
because,
any
as you
particular
said, that
group?
blood pressure is a silent disease. It's not picked up early or easily. It's only when you look for it, you will get it. So any kid more than 3 years who comes to you for a routine well baby follow-up, they should have a blood pressure monitoring done. I would recommend that strongly.
Okay. And suppose if you start this non-pharmacological, all measures that what you mentioned, then wait for around 3 to 6 months, monitor again, and then take a call on the medication, right?
Yes.
Okay. And what are the minimum investigation that, we can do, we should,
So,
ask for them before we
see,
start?
most common cause of hypertension in adolescence, I would say, is primary hypertension. If it's a younger kid, most common is renal cause. So you need to look at the kidneys very carefully, do a urine routine, do a burn creatinine, also do an ultrasound of the abdomen to look at the renal parenchyma, and renal artery stenosis is one of the common causes. So do a Doppler for arterial and venous thrombosis.
Okay.
And if there is a background of increased body mass index or obesity, then also in older kids you also get HbA1c as well as lipid profile to look at any dyslipidemia which would be associated and lead to metabolic syndrome.
Okay. And once you start the medication, so what are the medication you start and how we should monitor them? Like, is there any particular group that you prefer for a particular group of patient, particular group of drugs?
So most of the time, what we start is a long-acting calcium
Hello?
channel blocker like amlodipine, or we would use an ACE inhibitor or angiotensin
Kshitij, we
receptor
can't.
blocker.
Yeah. Okay.
So first line
We
would be either a calcium channel blocker or an ACE inhibitor or angiotensin receptor blocker, that is losartan or telmisartan. This would be the first line. If
Okay.
it's the older
Okay.
female patient, I would try to avoid receptor blockers and consider beta blockers in those cases.
Okay. Okay. And the target BP, if we start around 9, so it has to be less than 90th, right?
Yes, target has
And
to be
continue with the BP medication.
yes, target has to be less than 90th centile, and you continue it for at least 6 months. Try to then see how the blood pressure is. Get an ambulatory BP monitoring. You get the 24-hour BP control. If it is well controlled, then try to come off the medication or reduce the medication. But very important is compliance of the patient with healthy lifestyle. That is very important.
Okay. Another, moving on to another thing that we commonly see in pediatrics is the babies coming with a chest pain. So it's quite common. A 7-year-old came with a chest pain without any major, trauma history. So from cardiac point of view, how we should evaluate or, investigate these are the patients?
See, by and large, chest pain in pediatric age group is non-cardiac, as opposed to in adults where you assume it to be cardiac. So, chest pain in pediatric, by and large, is non-cardiac. Commonest causes being muscular pain, musculoskeletal pain like costochondritis, would be gastritis or gastroesophageal reflux. These are commonest causes. But sometimes, there is a history of, say, illness in the past, like a Kawasaki disease, or some patient who's undergone a cardiac surgery, or there is associated complaint of palpitation during the episode, or excessive sweating during the episode, or if there's a lot of parental anxiety, then it's better to investigate those chest pain. But most of the time, if there is non-specific chest pain, not typical of angina, and not happening during activity, then you can assume it to be a musculoskeletal pain.
Okay.
But parental anxiety is
Sometimes,
something which I emphasize on, because many a times, you might say everything is fine and parents are still anxious and just they keep on going to 10 people for opinion. So it's better if the family is very anxious, get it evaluated once.
Okay. Okay. Sometimes we do see patients, who are like coming with a palpitation history, like a 10-year or 11-year coming into the OPD with a palpitation history. So how to handle these patients, like, manage these patients and when to refer to you?
So see, palpitations are of two types. One is they feel that the heart is beating heavily, and second is where they feel the heart is racing fast. There are two different types of etiology, if at all, for both these kind of palpitation. So when they feel that the heart is pounding or beating heavily,
I think Kshitij, we can't hear you.
I think we
Hello?
can hear clear. We could hear. Nehal ma'am, can you hear?
Hello?
yes,
it's
yes,
quite
Tanushri is very clear. Tanushri is
it's quite clear,
We
yeah.
can hear him.
Your audio
Yeah,
and your
yes.
so palpitation could be either fast heartbeat or heavy heartbeat. So if it is fast heartbeat, then we need to find out whether that palpitation is at rest or with activity. Many a time these kids just run around and then they feel the heart is racing fast. So that is something which is normal. But if it is, you need to find out whether it is really fast or abnormally fast, more than 180 or something of that sort. So now what I tell parents, with so many gadgets available, just to keep a smartwatch and keep a watch of it if the episodes are very frequent, because it's difficult to get a Holter and get the ECG, exact ECG at the time of episode. So at least if you have a rough idea of the rate at which the heart is racing, it would give us a lot of clue towards the arrhythmia if we are dealing with. And if it is just heavy heartbeats, and in those cases, you need to examine the child well, whether there is a wide pulse pressure or whether there is second heart sound which is loud or murmur, which could be present in case of any valvular regurgitant lesion. So, kind of palpitation is important to differentiate what the underlying etiology would be.
So, sometimes there are patients, the obstetrician, they send us patients with, yeah. Am I audible? Hello?
Yes, yes.
Yeah.
Yes, you are. Yes, you are.
So, that another thing, I think we are just running short of time also. Sometimes the pregnant ladies are coming with a diagnosis of congenital heart disease. So, as a pediatrician, when you have to counsel them, so how we should counsel these parents or, mothers? So, with a fetus with a congenital heart disease.
So this is quite tricky. It depends on what has been diagnosed. Say many a time, they come with a report of an echogenic focus in the left ventricle, which per se has no clinical significance or relevance post birth. Only it could be a soft marker for some trisomies. And sometimes they come with report of ventricular septal defect where everything else is fine. So your VSD child who is born, it's a completely correctable disease. It is the current era, the success rate of surgery is around 98%. So it is completely curable. So in those cases, the parents should be advised to continue the pregnancy and reevaluate after birth. But if it is, say, a complex heart disease like a univentricular heart, where the outcomes, it depends on outcomes are not that great. They might require multiple surgeries, and in those cases, the parents need to be aware of the long-term outcome. So I would say that if they come to you and you are sure of the disease condition, you could counsel them. But anything more than a VSD, I would suggest you to refer to a cardiologist so that they can evaluate and counsel accordingly.
Yeah, and give them a proper plan subsequently how to go about it.
Yeah.
I think Kshitij is almost 10:41, and thank you so much and for this interesting discussion. I know this one session is less, and we would love to have you for another session to continue our discussion. Thank you so much. Over to you, Nehal ma'am.
Thank you, everyone. Thank you.
Sikha.
Yeah, thank you, Dr. Sitij. I think, like Nehal ma'am was saying, we sail through complex in a simpler manner now. So we have sailed through hypertension, hypotension, congenital heart diseases, and even vasculitic disorders. And very simplified, you have made it for all the pediatricians who have attended it. And also a big thanks to Dr. Tanushri for conducting it so well, covering all the topics which are relevant for the pediatrician. Also thank all the delegates who are there with us till this time and listening to the whole session. So thank you so much for joining in. So before we end, I would like to add that the next Webflix that we have in June is another very interesting and important topic for all pediatricians on nephrology. So please stay tuned to us. We have certain other programs which are in line in June. So on 16th of June, we have our very important module on gastrointestinal infections. So that is the grid module, which is at Saifi Hospital on 16th of June. And on the end, that is 30th of June, we have our vaccine CME at Sahara Star Hotel. So please do register for the same.
Also, 15th of June, we are having an asthma training module, mainly for postgraduate students, but of course, anybody is welcome. And this is going to be at Sion IIP office. So people who are affiliated, associated with any teaching institutes, private, personal, medical, government setups, please encourage your PG students to come. This is the updated GINA guidelines ATM module for PG students. And of course, our Webflix, which is going to come up as Sikha said. So thank you, Dr. Kshitij.
Thank you. I hope I have been helpful in some kind of.
Of course. These all topics.
Very much. Where 2-3 clinical
wonderful.
clues that we've taken definitely today from today's talk, which is going to help us for sure. Apart from the rest of the things that you've made simplified and very crisp.
Thank you. Thank you for having me here.
Thank you so much. Thank you.
Thank you.